welcome everyone. So it's our great pleasure to have Kieron Barclay, our own Kieron Barclay, in our department. I say it because Kieron was in the department as a physical researcher between 2015 and 17, and technically until 19. So he was around here, for some of you may remember him. And Kieron is an associate professor of social demography at Stockholm University at the moment, and much of his work is about relationship between health and mortality, but also a bit more intergenerational perspectives. He focuses on most of his research about parental family decisions and fertility decisions, how they affect children's outcomes across their life course in terms of health and education. And he has published many papers in this area, very much demographer. And I look forward to hear this talk like yourselves. So hang on with the slides.
Yeah.
Yeah, projector is not working, so we apologize for that too, like last week.
Yeah.
I tried to turn the lights on.
Something. Maybe you can turn the screen a bit. Oh, great, thank you. Yes.
Yeah, thank you so much, Berkay, for the kind introduction. It's very nice to be back. So thanks for showing up today. I can't really. Okay. Yeah. So this paper is like Berkay was saying, a lot of my work has been about thinking about the consequences of parental decisions for fertility decisions for their children. But I've also been doing some work that looks about the consequences of fertility decisions for the parents themselves. So thinking about sort of post-reproductive mortality, post-reproductive health, that kind of thing. So are there any kind of longer-term consequences of how many kids you have, or the spacing between them, or the age at which you have your children, that kind of thing. So this paper is about birth spacing and the health of mothers and fathers, and we're going to look at both physical and mental health outcomes. I'll say more in the next slide about how we're looking at these kind of health outcomes. It's quite a broad measure. And we're going to look at short-term and medium-term outcomes using some different approaches here. And I just want to acknowledge my co-authors, Martin Kolk, he's my longtime collaborator in Stockholm, and also this paper is also with Ozcan, who's based in Oslo, Norwegian Institute of Public Health these days. So what I'm doing today is going to be looking at how birth spacing affects parental health outcomes, and the way we operationalize that is looking at the number of general practitioner consultations that they have. And so we have these classifications based on, like in the ICPC, I think some international classification of primary care diagnostics. And so we use that to categorize into things that are more sort of physical health and things that fall into more of the mental health issues. This is what I'm using. I'm based in Stockholm, and I'm usually using Swedish register data. We don't have as good access to health registers as they have in Norway right now. So this is one of the few papers where actually my co-author has done the analysis here, because he had access to all this data, and it was much easier than getting me access to it. So we're using Norwegian register data. We can use a mix of individual fixed effects where we compare parents after the birth intervals at different lengths to see how often they're visiting a GP. And then for some medium longer term outcomes, so we're looking at short, medium, and long term outcomes. For these medium and longer term outcomes, we're going to do some sibling-fixed effects models. So we're going to sort of compare a mother to her sisters and look at their average birth spacing and see how often they visit a doctor, say 5 to 6 years later or 10 to 11 years later. So I don't want to overemphasize the sort of identification that we get from that, but I think it's a better control for the shared family background, which might influence preferences as well as health outcomes. And yeah, we're doing this for men and women, which is actually not done in the literature that often. Most of this literature focuses on women, for understandable reasons, of course. Yeah. So part of the motivation for this is there's a growing literature examining how birth spacing affects the health of children and parents across a wide range of different fields. But a lot of this focuses on particularly low-income countries, also middle-income countries to a certain extent. And there's relatively less in high-income countries for understandable reasons too, because yeah, there's less problems with very short birth intervals. They're more common in lower and middle-income settings. There's also less problems with prenatal supplements and malnutrition, all of these sorts of things, which seem to be a part of the association between birth spacing and negative outcomes for kids and their parents. So that's part of the motive. Of course, also people have smaller families in higher income countries on average. That's changing now, of course. But that is also probably very consequential for whether birth intervals matter a lot. And as I said on the last slide, previous slide, we're using individual and sibling-fixed effects. Most previous work in this area focuses just on controlling for observables. So we're going to try and net out some of these unobserved factors that might be driving both birth spacing behavior as well as the health outcomes that we're interested in afterwards. Yeah. Okay. So yeah, it's a social policy requirement, right? So and I do actually have these slides when I'm presenting this elsewhere as well, but I think maybe it's what I should really have them now. So there is interest in the policy relevance of birth spacing, both in lower income countries as well as higher income countries. The WHO recommends that people should wait at least 24 months after their previous birth before getting pregnant again, in order to minimize adverse maternal, perinatal, and infant outcomes. So including maternal mortality, infant mortality, and so on. But the American College of Obstetricians and Gynecologists also recommends that you have at least 6 months before getting pregnant again. This is a lot shorter, partly because of the wider availability of prenatal supplements and stuff that I was mentioning earlier. Yes, and of course, this recommendation is a lot shorter because of those differences in the context. I also want to emphasize that there have been some sort of accidental interventions that affected spacing behavior in the Nordic countries, for instance. So in Sweden, there was a so-called speed premium reform that was introduced in the 1980s. And this was related to parental leave compensation. And what was done here is that, so let me just say a brief word about parental leave compensation. It's based on your income prior to the birth of the child. And so what usually happened was that people got lower parental leave compensation after their second or subsequent kids because they were less active in the labor market. And so that meant that their income was, at a lower level in between, right? So what this intervention did was say that if you have your second kid within 24 months of the first one, then your parental leave compensation will be based on your income prior to the first kid, not this income between the first and the second. And that got extended from 24 to 30 months 6 years later. And so they weren't actually really thinking about shorter birth spacing per se. They were interested in reducing the economic impact of childbearing, reducing career disruption and others. And it was just thought to be part of a set of general family-friendly policies in the Nordic region. But it had the material consequences of reducing birth interval length. So I've spoken to people who were around at the time these conversations were happening, and apparently it just wasn't part of the conversation at all about whether this would have any negative consequences for the kids or for the mothers. So it was done sort of unthinkingly, at least regarding birth spacing. And so this is a paper from 2020, and you can see, so before 1980, average birth intervals, the median in years was somewhere like 3.75 years. And after these interventions, it declined quite a lot. I mean, about a year between the median. It's increased again a little bit, but you can say that between the introduction of these, the speed premium reform and afterwards, it did have a material impact on spacing behavior. And this is amongst women born in Sweden. There's also been some interventions in low-income countries. There's actually a lot in this space, but this is just a recent paper by Mahesh Kara and colleagues. And so they found that these kind of family planning interventions can have a very material effect on spacing behavior. So reducing the hazard of having a kid within the next 24 months by, the hazard down to 0.575 relative to those who weren't exposed to these family planning exposures, which is a really big difference. So I just want to emphasize that this spacing behavior is amenable to intervention. And so I'm going to present you the results later, of course. And so, if this matters for spacing behavior, I just want to emphasize that actually it is possible to change people's behavior with interventions. It's not actually that maybe as difficult as you might expect. So what does previous research show? They tend to show that there's a sort of J-shaped curve where both particularly short birth intervals as well as particularly long birth intervals are associated with worse maternal and infant outcomes. And so on the mother side, So there's not a huge number of papers in this space, but there was a systematic review by Conde Agudelo and colleagues, where I think they found 22 papers between the 1960s and 2006. And there's been a subsequent systematic review on 6 papers in the following decade. So yeah, a bit shy of 30 papers in total. They tend to find that these very short as well as longer intervals are associated with increased risk of things like uterine rupture, gestational diabetes, preeclampsia, and then also abnormal labor experiences. So some of these are very, very consequential, right? So preeclampsia can be deadly. Most of these though are in lower middle income countries, just because there's less in the high income country space. And what I wanted to say is also that most of these are based on observational studies. So there are only 2 studies that we could find at the time we were working on this, that use some kind of like a within mother design to try and net out stuff that might, unobserved factors that might drive both birth space and behavior as well as outcomes. So there's a paper by Hanley and colleagues using some kind of province level administrative data from British Columbia in Canada. And they found that shorter intervals, so comparing within a mother, birth intervals of different lengths, they found that shorter intervals were associated with an increased risk of gestational diabetes, as well as obesity. And there's a paper by Liu and colleagues which used data from California. And they were looking at severe maternal morbidity, which they put a bunch of different diagnoses in that category, including things like eclampsia and sepsis.
Sorry for asking the first clarification question. Yeah. So what does that within mother design means when the average birth is 1 and 2 in these settings?
Yeah, so they normally sort of categorize it. So it is the most common, but some people do have very short intervals and some people have very long ones too. So there is, I think, when you have this kind of state level.
But you can't have 2 intervals per mother to compare off of.
So you need to have at least 2 births, 3 births.
3 births, right?
So exactly.
And those would be very off of exotic samples in California.
To a certain extent, yes. So, but this is all there is, basically. Okay. So when you look at 1-child families, birth intervals just don't mean anything there. It is a more exotic population, but then it depends how you want to think about this. If you think about the universe of sort of observable birth intervals, most of those are happening in 3-child and larger families. So, you know, a 2-child family only has 1 birth interval to observe. There's 2 in a 3-child family, and so on. So from that perspective, if we're only interested in families where there are observable birth intervals, we have to look to a certain extent at these more unusual families. So, yeah.
But then, wouldn't it matter that the mother is actually aging and that the older the woman is, the more traumatic the birth can be, and just with age it becomes a risk pregnancy anyway, regardless of the interval between the first and the second and the second and the third.
Certainly people are also they're adjusting for like mental age at the time of birth in these models. And simulation models suggest that you can actually separate out these spacing effects from maternal age effects.
And the 4th child will be even more traumatic, even if you take age out.
Yeah. So it's looking at the average effect of spacing, once you net out the parity effects and the parental age effects. Yeah, that's what's usually going on.
Can I just ask, also clarifying question, it's not puzzled by the first policy slide that you show. What is the basis for those recommendations in the US?
So it's really, so it's basically, there are quite a few studies on things like preterm birth and labor and the risk of those at different birth intervals at different lengths. So that's what is primarily behind that policy advice. Yeah. So coming back to this paper by Liu and colleagues, I mean, so this is actually, they actually have a quite unusual result in the overall literature because they find that short birth intervals were associated with a lower risk of this severe maternal morbidity, and longer intervals were associated with an increased risk of severe maternal morbidity. So I would say that's almost like an outlier in the whole literature, and also quite different results from Hanley and colleagues, though looking at a different outcome. But for what it's worth, that's what's out there. Yes. So of course, part of the reason why it's really important to use, or at least I'm arguing that it's valuable to use these kind of within mother comparison designs or family fixed effects is because basically because there's selection. It's not birth intervals aren't randomly distributed across families. as you point out, with these more exotic families having larger family sizes, and also because very short birth intervals, for instance, are concentrated in certain types of families. It tends to be lower SES. It's more common amongst teenage mothers, for instance. And if you think about very long birth intervals, for instance, if we're thinking about health outcomes, there might be some unobserved factor that drives both very long intervals as well as health, if there's something that's affecting both fecundity and health. You might also think about partner changes, right? So if your relationship breaks down, then it's going to be longer before you have the subsequent child. And there's all sorts of literature on family complexity and family instability and how that affects parental outcomes as well as child outcomes. So I'll be presenting these fixed effects models because I think that it's valuable to engage with this potential selection issue, this confounding. Since we're looking at mental health outcomes as well, I just want to touch on the limited literature, and not limited in terms of its like design or anything, but there's just very few studies out there that's looked at mental health outcomes. So there's just really not very much out there. The literature that is there tends to suggest that short birth intervals may be associated with risk of anxiety and depression. Some research, well, there's really just one paper suggests it might be associated with an increased risk of parental divorce. And if we think about twins as being a kind of a case of very short birth intervals, then that literature also finds that parents of twins tend to have higher rates of depression and anxiety, even compared to parents who have closely spaced children who are not twins. You know, take that with caution because they're different types of families. It might be random if you have a twin or not, but it's a different experience from having two non-twin children, even if they're closely spaced. In terms of long-term outcomes, there's quite little. So part of the reason why I want to talk about all these different outcomes, even though we're looking at GPs, the number of GP visits you make, is because, yeah, this could have consequences. Our GP measure is it's very broad, right? So we're picking up anything from, small accidents where you might go to primary care to very severe things so it's really a mixed bag. Yeah.
I guess, so for GPs, because when I think about GPs in NHS and number of GP appointments I successfully get,
Yeah.
it's indicating something very different from my health condition. So what's the context in?
So I have to admit, I haven't actually lived in Norway before. So I think, honestly, I can't give you a very clear answer because I don't really know. I haven't really heard about this being a problem from my Norwegian co-author, that this is something that we need to worry about. But I don't have a good answer for it.
But the gist of that question is you are looking at the interaction of supply and demand services, where not actually the outcomes of people, but health and healthcare system interaction point.
That's true. That's true. Right.
Do you have data on the private appointments?
On the website.
Private appointments, what's the share of GP
It's-
appointments? I don't know how the healthcare system.
So it's a public system. So there are a small number of GPs who are not affiliated with the public system, but it's 99.4, I think, that is affiliated with the public system. So it's few people that are going outside of the public system. So we see the public sector visits that are being. That's what we have in the registers. So there's a little bit of research on long-term outcomes as well. Short birth intervals seem to be associated with higher mortality in adulthood, post-reproductive mortality for mothers and fathers. And there's a little bit of evidence suggesting that it's associated with higher morbidity as well, higher rates of cardiovascular disease, for instance. Yes, so I just want to talk about some potential mechanisms before I start to get into the data. So that was just more the empirical literature and what the people argue is driving these kind of results. So it's not actually something I didn't say at the beginning that I should have done, which is very important, is that these short-term outcomes, right? We're looking at outcomes 1 to 5 months after birth, as well as 6 to 11 months after birth. We are trying to exclude directly pregnancy-related outcomes because there is some literature on that topic already. There's less literature that focuses on sort of more general health outcomes, even though it is actually what we're measuring is the combination of supply and demand for healthcare, primary healthcare. So we're not looking at direct pregnancy outcomes, okay? Like postnatal depression, for instance. But we will pick up consequences of poor, follow-up consequences of poor pregnancy outcomes if they linger. Okay. So some important potential important mechanisms to think about, so that they're thinking about the sort of physiological processes that link birth interval length to maternal health outcomes, and then subsequently the follow-up consequences of those later on in the first year after birth, as well as 5 to 6 years later, 10 to 11 years later. So I'm going to talk quickly about that, talk a bit about the potential, whether the stress of childcare is related to is it part of the mechanism for how birth spacing affects subsequent health outcomes, and then also come back to the selection briefly again as well. So thinking about the potential health consequences, most of this seems to, so the physiological processes that people are talking about when they're talking about the relationship between birth interval length and maternal health outcomes tends to be things like maternal nutrient depletion, and some more uncommon things like incomplete healing of the uterine scar if you have a difficult pregnancy, for instance, or very dangerous, but maybe not that uncommon outcomes like preeclampsia and the negative health sequelae of these kinds of outcomes. Of course, this literature it focuses on mothers. There's nothing about fathers in this space. Talking about the stress of childcare. So I looked at my slides after I sent them, and what I want to say isn't really about how spacing between children can affect parental time and attention, but more about how it affects the intensity of the parenting experience, if you will. So the idea really is that if you have kids that are more spaced out, that's going to spread out the kind of the stress, anxiety, and the challenges that come with like raising children over a longer period, rather than having multiple very closely spaced children. But the overall idea here is that if you're stressed for an extended period of time, if you have multiple closely spaced children, you're going to have a prolonged period of stress. This might affect, your desire to seek mental health care, for instance, and insufficient rest is bad for health in general. Of course, there's also something that I think it's valuable to think about combining childcare responsibilities with employment as well. Norway is, relatively speaking, like a relatively egalitarian country in terms of gender equality, but this pattern still persists there that you find in most other industrialized countries and less industrialized countries where women are still taking the majority of the care for children, of course. So this should in theory fall more on the mothers still. But I just come back to this briefly again about the selection processes, because birth spacing is not randomly distributed across families. Tends to find shorter intervals amongst families with lower SES, teenage mothers, and with potentially worse health, like I was saying before. Short intervals are also more associated with unplanned births. So the one exception to all of this is really that high SES parents are more likely, if they start their childbearing at a later age, they're more likely to pursue an accelerated fertility schedule because they might have a desired number of children, 2 or 3. But if they start like at age 35 or something, they might have to have shorter birth intervals than they originally might have planned. But otherwise, short birth intervals tend to be concentrated amongst sort of less advantaged groups. I've done some work on looking at kids' outcomes in relation to birth intervals as well, using sibling-fixed effects. I'm going to show a couple of results there very quickly. What we find there is that where we do sibling comparisons, holding constant like shared family background characteristics, there doesn't really seem to be any meaningful negative effect of short or very long birth intervals on kids' outcomes. So we've looked.
Can I ask you, do you have breastfeeding data?
No, unfortunately not. In theory, there might be some stuff like that in like the medical birth register. But most of that data is collected during the pregnancy and not afterwards, I think. So I don't know. We don't have it in the registers as far as I know.
Some of those correlations may have to do with breastfeeding, so higher earners, higher
Yeah.
educated couples are not having to breastfeed their children. Therefore,
That's
naturally, they're.
That's true.
breastfeeding.
I mean, so most of the literature shows that breastfeeding is good for the kids, right?
Yeah.
Some of it suggests that it's a bit, like there's some sibling, yeah. So yeah, that's true, And we do, that's part of the reason why apparently, mothers tend to have lower rates of breast cancer even, in the long run. Yes. So it could matter. But we
It
don't.
also affect the spacing, no?
Yeah,
Yes, exactly. Yes, that's also.
it's related to the spacing and health.
Yes, that's right. So unfortunately, we don't have that. So I think to a certain extent, when we use like individual fixed effects comparisons, there might be some stability in terms of sort of individual propensity to breastfeed children. But we also know actually that changes by parity. So to a certain extent, by controlling for parity, we control that away. But nevertheless, it's not like, yeah, a mother breastfeeds all her children equally on average. So I agree, it's important to think about that. In terms of what we've done in the past on looking at offspring outcomes, actually, we've done a few papers on this in Sweden as well as in the US, where we use the Utah population database, which is like a state level population register. And in these settings, we've looked at a wide range of different educational and SES outcomes as well as health outcomes. And this is just sort of I think, a representative example of what we find here. So if we're looking at years of education by age 30, for instance, the left panel, we're looking at the length of the interval preceding the indexed person, and the right panel is the length of the interval following the indexed person, so the birth of their next youngest sibling. This red line here is where we don't use a sibling comparison analysis. So we control for some basic socio-demographic factors, but we don't control the family background. And here you find this kind of J-shaped curve that I mentioned before. So kids born after shorter birth intervals relative to the reference category here, and kids born after longer birth intervals, they seem to have lower educational attainment by age 30 in terms of years of education. When we do the sibling comparison model, which is the blue line here, we basically wipe out most of the negative effect of birth spacing. So this is full Swedish population register data. It's a relatively precise null. So at least to us, the way we've interpreted these results is that a lot of this is just being driven by selection at the parents level about having short birth intervals. So that doesn't mean, right, the kids are having lower education who are born after, they are achieving less education if they're born after very short or very long intervals, but it's not about the spacing per se, it's the factors that are driving short and long birth spacing. And this is we found something very similar in the US as well. So this is the probability of obtaining a college degree, linear probability model. In this case, the orange line are the sibling-fixed effects.
Well, Utah has the right sample, right?
Yeah, exactly. So they are definitely less exotic families.
For Utah.
Yeah, they're exotic at the state level.
Yes.
Okay, so let me get to what we've been doing today in some more detail. So using Norwegian population register data, we have data from mothers and fathers. We have data on everyone, but the furthest we can go back to link parents to their kids is people born in 1935 or later. In practice, because we have data from these health registers on GP visits over the period 1996 to 2017, we're looking at parents who were born a little bit later, but we can observe all of their birth. And we're going to look at RDs 2 to 5. So, yeah, this is the exposure that we have for the birth space. What we do here is we actually, even though I talked about twins a little bit earlier, we exclude parents who have twin deliveries. I think it would actually be interesting to look at that, but I think it's more of a separate study. It would necessitate a separate analysis, I think, rather than just controlling for the twin delivery. So this felt like a cleaner design when we went this way. The outcome variables is the annual number of face-to-face GP consultations over this period, 2006 to 2018, where we have the GP visit data. As I mentioned before, we use this international classification of primary care consultations to classify mental health visits for mental health concerns and visits for physical health concerns. As I said before, excluding those that are directly pregnancy related. And I think, I mean, this came up a bit earlier, but I just want to emphasize again that if you need specialized healthcare, so unless it's an emergency, right, and you go directly to the emergency room, if you need specialized healthcare, like most places, the first point of contact is a primary care consultant. So we should pick that up, even though it's a very general and broad measure that captures visits related to things of all different levels of severity. Is that okay?
Yes, so I was trying to understand your data setting. So you want to exclude the people who have had child loss. No, include the people who had child losses, as long as they have one child living in the parity of 2 to 5. But how about step families and adding other children? You know, what is it about the spacing that we care about? Is it the actual given birth? It's not the case for men.
Right. So I think for men, I think we are kind of interested, even though we can't actually measure them, in those other different types of mechanisms that I was talking about before, kind of consequences of negative physiological experiences or physiological mechanisms, but also the stress of raising kids, which could apply to fathers as well, of course. And then also the selection dimension of this. So we're going to compare the result. I'm going to show you the results comparing, like I did for the previous slides, with and without these fixed effects, sort of asking how much of this relationship still persists after we sort of hold individual level factors constant or shared family background factors constant. Yeah, so that's we look at these two different short-term outcomes. The reason why we do this actually is because there's a risk of pregnancy overlap as well, which might affect the data and our results, but it's much less likely that mothers would be pregnant again 1 to 5 months after. It actually is almost not existing in our data. The period that we're looking at for medium and long-term outcomes, it might seem a bit random, but we've explored different options. This was just, yeah, it's a little bit arbitrary, but it's not like our results are particular to looking into 5 to 6 years after birth or 10 to 11 years after birth, for instance.
Sorry,
Yeah.
the 1 year to 4 years, is it short term or medium term?
So the short term, we looked at 1 to 5 months after birth, and then 6 to 11 months after the birth. For the medium term, we look 5 to 6 years after the birth. Yeah.
Okay, okay.
Yeah. So these two, we use the individual fixed effects models. These two, we're going to use the sibling fixed effect models. Okay, and I'm going to come to more details about the models in a few slides. Oh, here. So I don't want to infantilize you. I made these. I made these for a previous presentation, and I'm not sure if they're useful or not. I think they might be slightly more useful for the sibling fixed effect models. But yeah, for the individual fixed effects, we do this separately for mothers and fathers. We actually, sorry, you asked about step families, and I missed that part of your question. So we include all children born to a mother, and as I'm going to show, we control for if the partner changes. But we're not otherwise explicitly like stratifying by family type or number of different fathers or mothers, for instance. So,
But for fathers means, imagine that you had a child, you separated and then have a new fiance, had another child. For the father, the spacing is very short.
yeah,
But for moms,
Yeah.
different moms, the spacing is very different, so.
that's true. That's true. So so there will be some cases like that in our data. Yeah. So we don't actually deal with that very well, I guess, because all we do is control for whether they change their partner or not. But, yeah. No, actually, that's would be good to go back to. I'm going to show you the. Oh, sorry.
Do you have data on how many kids are there in the new family? Because you have 3 kids, you get a new partner, you end up having 6 kids
Yeah.
next day, and then looking after 6 kids is completely different from looking after 3 kids.
That's absolutely true. So actually, we do have that.
Stress.
Yes, exactly. So actually, we do have that. I'm not going to be showing you anything that takes that into consideration. But in theory, we like from a certain period, we have a detailed cohabitation register, which I think is like 2004. So we can see who they're living with and how many of them are children below a certain age, for instance, or something. So we could investigate that as an explicit test. I'm gonna show you the results. So 1A is for like looking at 1 to 5 months after birth, 2A is looking at 6 to 11 months after birth. So these are kind of like parallel models for the two different outcomes that we're looking at. So I'm gonna first show you the result from linear regression without any individual fixed effects, where we just control for parental age at the time of the birth and their parity, and we use the full sample. So we don't condition on them, actually, so in this case, we don't condition on them having at least 2 births. Okay. In this case, in the second model that we're running, we still use a linear regression, but without any fixed effects. But we use the fixed effects sample, if you will. So the sample of parents, mothers or fathers, who had at least 2 births, so we can observe 2 intervals. So we have within parent variance on the birth interval length in theory. We introduced some additional control variables here as well, not only just for parental age and parity, but also parental education, the marital status, cohabitation. In many cases, this is not actually changing between, especially parental education. But yeah, we've also been in the review process, right? So we introduce additional control variables along the way. And as I was saying in response to your question about Berkay, we control the co-parent change as well. So this is a fixed effect sample, but no fixed effects. And then finally, model 3 is basically model 2, but we use that sample, same control variables, and we apply the individual fixed effect comparison. Okay. So then we're going to hold constant sort of unobserved factors at the mother level or the father level that might drive birth-spacing behavior, as well as the number of GP visits, including, potentially propensity to seek out care from a doctor as well, right? If that's constant within individuals over time. So I think the graphic maybe is a little bit more helpful for the sibling-fixed effects model, just because there's a bit more going on here. So what we do, let's say so in this example, I'm talking about fathers. So we compare brothers who are nested within the same mother. We take the mean of all their birth interval lengths, and then we see how many times they're going to a doctor 10 to 11 years later, or 5 to 6 years later, and we compare the number of visits that they're making to their brothers. Yeah. So, as I said before, sorry.
So this analysis requires another specific group of people that not only you, but you and your sibling both
Exactly.
have at least 2 children.
Exactly. Well, yes, exactly. So we do get to a more selected sample, but kind of we see that as a negative side effect of trying to have a cleaner identification. So I agree. It's like there's more. It's necessary to think more about the potential implications of doing that selection on the sample. But yeah. So as I said before, I think this is definitely. I think the individual fixed effect approach is a better identification strategy for identifying the effect of birth spacing, and this one should be. But I think it makes less sense the further and further away that you go from the birth interval to a certain extent. Though I guess we could have tried that too. But so this should be, I think the strategy should be thought of more as like a more effective control for their shared family background factors. Not only like health, but also stuff that might shape the preferences for the number of kids, number of how they space the kids and so on.
Just to follow up, and then another clarification question.
Yeah.
Do you have the percent of the population that fits into this category, just so that we see how many people it is approximately?
I don't have it off the top of my head. So the numbers are around like 150,000 in these models. So, but yeah, as a percentage, I don't have it off the top of my head.
And just a second question, I'm sorry if you said it, but how do you deal with births that have potentially severe disease or handicap that might affect both stress and birth spacing?
Well, I think that would just be part of our outcome, I think. Yeah, so if that, for instance, so if you have a kid with a kind of a developmental issue or something like that, and that affects the stress of parenting, and that affects like how often you're going to a doctor for yourself, not for your kid, then that would show up in the results. But otherwise, we're not like explicitly controlling for the health of the kids.
But can you see if that might drive some part of it too?
Yeah, actually, that's a good suggestion. I mean, we could explore that, I think. I think we could. I would have to ask Ozcan because he's more current with like what's actually in there, how old you are, or you start to show up in the health registers. Yeah, but thank you. So here, it's also like a set of parallel models, kind of similar to what I was talking about before. So 3A is 5 to 6 years after, 4A is 10 to 11 years after. So similar setup to before. So linear regression, no sibling fixed effects, where we control for average parental age at the time of the children. And we control for their completed parity, so how many kids they got by the end. And again, we use sort of the full sample. And then we have a model where we condition on them having siblings and having at least 2 births, each of the siblings, where we control, but where we don't use the sibling fixed effects. And then we also control for parental education, marital status, and any co-parent change. And this we control for actually at the time of the start of the health follow. And then model C are the same as B, but we introduce the sibling fixed effect. So one thing you might be thinking about with both these and the previous ones that I talked about is whether what's happening is because of the sample change or because of the control variable change. And so we've done comparisons where we keep the sample the same, but of the same control variables and the other way around. That doesn't really affect the results. Yeah. So it's more like, it's more the fixed effects that seem to be changing the results, which I'm going to come to very soon. I'm going to show you some of the script. I'm kind of a demographer, so I'm going to show you some of the script that I hope you're going to see. So these are for mental health outcomes. So just to give you, so this is for men and women. Women are in red, men are in blue. This is for 1 to 5 number of visits, right? This is for 1 to 5 months after the birth, 6 to 11, 5 to 6 years, and 10 to 11 years. These are more or less unconditional. So this is, so this is reflecting also parental age and this kind of stuff, which is why it's more common to go to the doctor, 5 to 6 years or 10 to 11 years after the birth. But what you do see is this kind of, U-shaped curve, if you will. So mothers and fathers are more likely to seek care from a doctor for mental health concerns if they have very short birth intervals or also longer birth intervals. Now these look flatter here, right? But if you zoom in, basically it's just the same. It's just because the scale really makes these ones look small. The other thing you might be thinking about is what is this 6 to 11 months interval? Like how common is that? If you're anything like my other audiences. So I just want to emphasize that this is very, very uncommon. So we're using full population register data, so we also observe some very unusual things. It's still real data, so we don't want to throw that out. But we only observe 2 observations, for instance, where we have a 6-month birth to birth interval. So it's 2 at 6 months, like 6 at 7 months, 36 at 8 months. So it's very uncommon. We just don't throw them out, but they're not driving our results. And these are the descriptors for physical health outcomes. So if you compare these, so the scale here is from 0 to 5. So it's a lot higher than for the mental health outcomes. So it's just a lot more common to go to the doctor for physical health concerns. Okay. Not surprising. But otherwise, we find a kind of similar descriptive pattern by the length of the birth intervals, both for men and for women. So now I'm going to get to some results. I'm just going to explain the setup of these panels because the 4 graphs I'm going to show you, they're all going to follow the same format. Okay. So the leftmost panel is going to be, so this is for 1 to 5 months after birth. So this is the individual, it's going to include the individual fixed effects analyses, even though only one of them actually uses the individual fixed effects. So look at mothers for mental health outcomes, fathers for mental health outcomes in panel 2, and then mothers for physical health outcomes, and then finally fathers for physical health outcomes. And in each of these, I'm sorry, it's not bigger, but this darker blue line is the full sample. Then the lighter blue line is the individual fixed effect sample, but without the individual fixed effects. And of course, well, I would argue the one to keep your eyes on is the red one, where we have the individual fixed effects here. Okay. And the scale is just the actual absolute number of visits that they're making. So overall, I think it's worth saying that the results are not very large, even in the models where we don't really control very carefully. So there isn't a big association there, even when we use the full sample, don't really control for much apart from parental age and parity. So relative to the reference category of 24 to 29 months, for instance, those who had a birth to birth interval of 6 to 11 months, they're only going to a doctor, this is the blue line, the blue data estimate, like 0.0 times more than the reference category, 0.05 times more than the reference category. And that's the same with the very longest birth intervals as well. And with the sibling fixed effects results, this basically completely,
Sorry, it's a very basic question, probably I've covered it. So there is no interaction model, right, with socioeconomic status or?
No, that's right. So this is just the full, so we control for in the light blue one, we control in the light blue estimates, model B, we do control for maternal education and her marital status, but we don't stratify by SES or do anything else apart from what I just said. So of course, the individual fixed effects is going to pick up a lot more, hopefully all of that in turn. So for mother's mental health, so I would say overall, you suggested it doesn't really matter very much even when we don't condition for things very much. But when we introduce the individual fixed effects, it's even smaller. So there are a couple of statistically significant differences, but if it's 0.04 and it's lower for father's mental health, I would say there's not an awful lot going on here. That's my takeaway. You might disagree. The results are bigger also, the differences from the reference category for physical health and for mental health, and that's going to be true across all the results. So if we look at mothers, for outcome GP consultation 6 to 11 months after the birth using the individual comparison. I'll just talk about, I know I may be going into time, so I'll focus on the individual fixed effects results. So there's a little bit of evidence maybe in some cases, like the mothers for care seeking for mental health issues, that they go to the doctor more if they have a birth interval of 6 to 11 months compared to if they have a longer one. But yeah, they're going 0.09 months. So as I'm going to say when I summarize this, I think overall, just the fact that the absolute differences that we're observing here are quite small, it suggests that this is not such a big issue in a setting. Yeah, I'm just saying that very similar results for 6 to 11. And now if we look at the results for 5 to 6 years after birth, so the medium-term outcomes, where we use, like I said, I think the less effective identification strategy using sibling fixed effects just to control a bit better the shared family background characteristics. We do find some differences here. So maybe 5 to 6 years later, moms who had very short birth intervals, maybe they're more likely to make one extra visit to a doctor for mental health issues. Maybe that's not so small. I mean, maybe most people don't go to the doctor for mental health issues. So if you go once in a year, maybe that reflects something that actually is quite salient, at least in your experience, for anxiety or depression or something, but yeah.
Yeah, I think this is bothering me a little bit because I've worked with GP visits as well, and often, so it's not just me, but often the referees will tell you, well, maybe this is a good sign, right? The more visits to the GP, both for physical things or mental things, is just showing that this person is actually takes better care of themselves. So Yeah, just maybe not now, but just.
Oh, no, I think it's a good point. I mean, so I think so to a certain extent, I think that should get picked up with the individual fixed effects. If they, have a stable propensity to look after themselves, to seek care and so on. But that also might be why we find a bigger difference here, because we're not controlling for that individual propensity as the sibling impacts. Yeah, sorry, that's what you have first.
Thanks. I don't really know much about the Norwegian system, but here, if it's something that is severe enough and the GP decides that, or like specialist enough, they'll refer you to a specialist, and from then on, it would be the specialist looking after you.
Wow.
So you might actually have a severe depression, then you would be referred to a specialist service, and you might not even visit your GP for this thing for the next 10 years, or you might hope you feel better in 10 years anyway, but
Yeah.
the idea is that the specialist will be the one person that will give you regular appointments and look after you, etc. So do you have any way of tracing these cases that the GP just says, no, I don't, it's not me, it's somebody else, and
No,
you
that's
still
good.
have regular appointments,
Yeah.
you're still not well, but it's not your GP.
Yeah, no, I think that's a really good comment. I mean, I agree. So I would have to ask Ozcan about that, but I can definitely see that that would be the case. So these might it's possible that one way of interpreting the way you might want to interpret this is for visiting a doctor for separate issues. Whereas, yeah, like any kind of severity is not reflected in this because it's about, that'll be picked up by the, like you say, subsequent visits to a specialist. Yeah, I will ask him. Did you have your hand too?
No.
Okay, so, and maybe we also find a slightly higher, okay, it's not even statistically significant, but we find a slightly, the point has been suggested you're maybe more likely to go to a doctor for physical health concerns after 5 to 6 years as well. Yeah, and this is 10 to 11 years later. So I think that maybe these results suggest for mental health suggest that probably if there is any association, it's more a short-term thing, or at least short to medium term. And for these for physical health issues, maybe there is a slight propensity to continue to need. Yeah, maybe there are some consequences, but on an absolute scale, it's actually, maybe it depends, it's not so small. I mean, I don't go to the doctor very often, so it's like if you're going an extra time a year or 2 times a year, I would, for me personally, that would be like a lot, I think. But of course, it depends what your baseline is. So we try and control that, right, by controlling for their educational level, by controlling for their shared sibling background and so on, but I think it's important. So I'm gonna wrap up here so there's time for more questions. Overall, the result from the associational analyses show that, yeah, people make more visits to the doctor for mental and physical health concerns after very short birth intervals and also longer birth intervals. But overall, the associations are smaller when we hold constant either stable individual characteristics or the shared family background characteristics. And overall, I think, largely speaking, I would say they're small in magnitude. And some of this, at least these kind of weaker effects that we find after using the individual effects suggest that some of what's driving those results is selection. I've said this a bunch of times already, so yes. Yeah, well, the only other thing that's important, I think, maybe to think about is that, which I also mentioned, is that we can have this kind of complicated problems when we look at outcomes like 6 to 11 months after birth, for instance, because if the short interval is correlated with maternal health, and that's correlated with getting pregnant again, that will affect your exposure at the time to the next birth. And so this is certainly a complicated thing that's actually, it's a little bit tricky for us to actually solve in our estimation. So I think it's worth keeping that in mind. Oh, I think I said this a lot already. So I think we are capturing health-seeking behavior to a certain extent. To a certain extent, we're able to hold that constant, I would argue. It's more of a concern in the sibling-fixed effects models, I think. And finally, I would just say, like, be careful about generalizing. Of course, Norway is a highly developed, very rich welfare state that spends an awful lot of money on healthcare for its citizens and residents. And then, of course, since we're excluding outcomes that are directly related to pregnancy, it's important to be careful about generalizing this to directly pregnancy related outcomes. Yeah, but thanks for coming.